Case presentation number 1. 62-year-old male with chronic right knee pain, bilateral leg edema, worse right leg edema for the last 3 weeks. He's been wearing compression stockings daily for many years. He's desperate for a right total knee replacement, but the ortho surgeon will not do a knee replacement due to chronic venous disease. Past history, one of my partners did a left leg venous ablation of the small saphenous vein. He's had 13 right knee surgeries. He also had right knee sepsis in 2020, keeping him in the hospital for like 6 weeks with multiple knee debridements. On exam, bilateral, he's got palpable pedal pulses, 2+ bilateral leg edema, visible right thigh varicose vein. This is his leg. Took the pictures earlier this week, and looks like you can see a varicose vein here. That's actually the great saphenous vein. I tend to do my own mapping in addition to the venous reflux testing that we do. And so he has severe reflux of the great saphenous vein. It's in its usual sheath. It leaves the sheath at the calf, you can see there, rising up. And then at the mid-thigh, it dives back down into the sheath to become the saphenous vein again, and it is patent with, it's dilated and refluxing. So then I said, okay, you know, I can probably treat this. I don't know if it's going to convince the orthopedic surgeon to do the total knee replacement, but you know, we can try our best, and I can't make you any promises that he's going to go for it. So I get a venous duplex, venous reflux study, and it shows a iliofemoral right leg DVT. This is a common femoral vein. There's a little bit of what you call signal bleeding from the adjacent femoral artery, but that's got occlusive thrombus in the common femoral vein. The deep femoral vein's open. Femoral vein is occluded. You can see that there's no color flow there. And then the popliteal vein is also occluded, and this is just the popliteal vein here. You can see the popliteal vein is non-compressible. So my tech asked me, can we do the venous reflux study or still? So I have a question for the panel. If someone comes in with a history of DVT, how old does the DVT have to be before they can get a Hokinson pump to do the venous reflux? Anyone? How about you, Tino?
I'll tell you, in our hospital, we don't do it. I don't think you're going to be. It's going to be that risky, but it's one of the protocol things that we have. But I do wonder if the patient's undergoing this acute thing, if what you're going to find is really going to be, you know, what's always present. In other words, are you overemphasizing maybe some of the reflux because of the DVT? And I don't know the answer to that. I'm curious what everyone else thinks.
Yeah, no, I think that's a great point, Tino, is that the reflux, if the iliac is out, the reflux is probably going to be worsened because of the outflow obstruction. And I agree, we would not do the typical study, but I think it'd be interesting just to stand this do reverse from Dellenberg and kind of do a measurement even without Valsalva or augmentation to see if there's severe reflux there, which I wouldn't be surprised if there was.
All right, so that answered question number 2. So for the panel, would anyone offer this patient pharmacomechanical thrombectomy? So for someone basically has a popliteal, femoral, common femoral DVT, the deep femoral vein is spared, there is trailing thrombus that goes up the external iliac vein, and the tech, when he called me, he said, you know, it looks pretty poorly adherent up there. It's like a trailing thrombus. So, Dr. Muck, how would you approach someone with an iliofemoral DVT with a trailing thrombus? How would you access that? Where would you access? And what would be your go-to device?
Yes, so I think, you know, timing and history is always hard to get from patients. I think Tino or somebody mentioned that earlier. So I think it's hard to judge that, but what we typically do is before we move them over onto the table, we'll do an ultrasound of the upper medial calf. If I feel like we can go high posterior tibial, then I'd go that way. If not, I'd flip them over and go as low as I could on the popliteal. And then I would try the, aspiration thrombectomy, and I would use flash for this particular patient.
Mark?
One of the things I will say is that I think it's really important is that oftentimes you'll get that day one of symptoms, and then you try to figure it out, and you can also look at the ultrasound and see if it's really echogenic thrombus that does not appear to be acute, and whether or not you've got good coaptation or not, to help maybe somewhat decide the age. But I very strongly believe in the wire test, which is where going up and feeling it with your catheter and wire and that tactile sensitivity we talked about yesterday, that really tells me so much. And then at that point, I decide what I'm going to do based on that. If it's really soft and the wire flies through, I'll use one of the devices such as AngioJet or JetI or something that's for some acute to subacute DVT. If it's extensive, hard, chronic stuff, then I would go to the Access PTS ECOS system to treat.
And do you go proximal, so you start distally and go up, or are you worried about that kind of poorly adherent thrombus in the external iliac vein? That's one question. Second question is there a role for coming from the jugular?
Hey, Tim, I think the one thing you're trying to get at is, do you need an IVC filter, and does your approach have to be from above first because of this free-floating or non-wall adherent clot? I think that's what you're trying to get at, right?
Yeah.
With your discussion. I think in general, this looks mostly like it's at least subacute to older clot. I think we all agree that. Whether there's acute clot there or not we'll have to figure out. I think when you look across the country, maybe half the operators will say, I need a filter in this case. Others say, I've done it for decades without it. I don't think we have data to tell us what's the right answer. I think it ends up becoming an experience thing. I think this patient in general, I'd have to see, when it's non-wall adherent, we tend not to put in filters most of the time. I would actually approach this like, my colleague here was saying, if there's a posterior tibial vein, because you got to get, outflow from that calf if you're going to make this patient better in the long term. And so if I can see a good posterior tibial vein, I actually would get access there. I would also get jugular access as well, just because I'm not sure what I'm dealing with, or if I can get a CT venogram ahead of time for just treatment planning. But that's kind of the thought process I'm going through.
Yeah, I should have elaborated more. Once you cross your thrombus with your hydrophilic catheter and wire, you do a vena cavogram. Only if it's extending, up near the renals would I consider a filter. I don't think a filter is a sign of weakness at all, as long as you can get them back and get it out within 4 to 6 weeks. But then as you aspirate, yeah, you're turning it on and going from peripheral to central with the device on.
And a lot of times in our center, if we're worried about it, we'll just put a filter in, treat them, and if everything is cleaned out for the most part, a single session ideally, we'll just take the filter out either that same session or the next day.
Alan, you want to say?
Yeah, I was just, that in a subacute circumstance, I'd probably not put a filter, but again, it's, it's such an easy thing to do. If you're worried, just put it in. Because it's probably subacute, I'd probably use an Inari rather than one of the aspiration devices to get the clot out. I've been very impressed with that device, especially for the more chronic clot.